Hello, everyone, and welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever your curiosity calls. I'm Yazan Qawas, your host for today's episode, and joining me is Omar Arnab.
Hey everyone, thank you Yazan for the amazing introduction. Today we're talking about anti-epileptic drugs. This is honestly one of the trickiest pharmacology topics, but once you understand the logic behind them, everything starts to click.
Before we even talk about the drugs, we need to understand what epilepsy actually is.
Alright, so epilepsy is a neurological condition where a person experiences recurrent seizures, and the key word here is recurrent. A seizure itself is caused by abnormal excessive electrical activity in a group of neurons in the brain. Normally, neurons fire in a controlled and organized way. But in epilepsy, a group of neurons suddenly start firing rapidly and uncontrollably. This abnormal activity can start in one area and then spread to other parts of the brain.
Basically, neurons are firing way too fast and out of control. So you're saying that depending on which part of the brain is involved, seizures can present in different ways?
Precisely. For example, patients might experience convulsions, which are uncontrolled muscle movements. They may even get muscle spasms or may even lose consciousness.
I heard that most people confuse seizures and epilepsy together. Can you explain the difference to our audience?
Sure thing, Yazan. A seizure is a single event, a one-time episode of abnormal electrical activity in the brain. Epilepsy, on the other hand, is a chronic condition where a person has two or more unprovoked seizures. So you can have a seizure on its own without it being full-blown epilepsy.
Wait, how does that happen?
Because seizures can occur in many other conditions too, like brain tumors, infections, head trauma, and even strokes. So not every seizure means epilepsy. And that's actually why many doctors prefer the term anticonvulsants instead of anti-epileptic drugs, because these drugs treat seizures in general, not just epilepsy.
So anti-epileptic drugs basically suppress abnormal electrical activity in the brain regardless of the cause.
Yup, that's about it.
Now, Omar, seizures aren't all the same. What are the main types?
Seizures are broadly divided into two main categories: partial seizures versus generalized seizures. Which one do you want to start with?
Let's start with partial seizures.
Partial seizures begin in one specific area of the brain. There are two types of partial seizures. First, simple partial seizures. These usually last about 30 seconds to 1 minute, and the key feature is the consciousness is preserved. So the patient stays awake, but they might experience localized sensory symptoms or twitching of one muscle group, like twitching in just one arm.
So simple partial seizures are focal symptoms with the patient staying conscious.
Yeah, then we have complex partial seizures, which usually involve the temporal lobe. These last longer, around 1 to 2 minutes, and they often begin with something called an aura, which is like a warning symptom before the seizure. But the key difference here is that the consciousness is impaired. The patient might appear confused, perform purposeless movements, or not remember what happened afterwards.
So in simple partial seizures, the patients are conscious, while in complex partial seizures, they have impaired consciousness. Now, what about generalized seizures?
Generalized seizures involve both hemispheres of the brain, right from the beginning. The most classic type is the generalized tonic-clonic seizure, also called grand mal seizures. These are dramatic, and they usually follow this sequence of events. First, the patient may experience an aura, then a loss of consciousness, then a tonic phase where muscles become stiff, followed by a clonic phase which involves rhythmic jerking, and finally, the patient enters a prolonged sleep or recovery phase. This whole episode usually lasts about 1 to 2 minutes.
And that's the classic seizure presentation we imagine. There's also a type called absence seizures.
These are a big deal on the other hand. They're very different. Absence seizures are common in children and involve a brief loss of consciousness, usually lasting about 30 seconds or even less. The key is that there is no convulsions. Instead, the child might just freeze and blankly stare into space. It can look like they're daydreaming.
So absence seizures are short, subtle, and easy to miss.
Precisely.
Are there any other types?
We do have a few other types. There are atonic seizures, where muscles suddenly relax and the patient may fall, and myoclonic seizures, which involve sudden muscle jerks. We also have infantile spasms, which occur in infants. And finally, one of the most dangerous conditions is status epilepticus.
Status epilepticus is a medical emergency, isn't it?
Oh, it absolutely is. Status epilepticus happens when seizures occur repeatedly without recovery in between. So the brain never gets a chance to reset. It can lead to permanent brain damage or even death if not treated immediately.
Now that you understand the types of seizures, let's go a bit deeper. What's actually happening at the cellular level? Why do neurons suddenly fire uncontrollably?
Now, this is where things really start to connect. Normally, the brain maintains a balance between excitation and inhibition. Excitation is mainly caused by glutamate, which allows sodium and calcium to enter neurons, making them more likely to fire. Inhibition, on the other hand, is mainly caused by GABA and glycine, which allows chloride to enter and potassium to leave, making neurons less likely to fire.
So excitation is turning on neurons by glutamate, while inhibition is turning them off by GABA and glycine.
Way to go, Yazan. Now, in epilepsy, there's either too much excitation or too little inhibition, so neurons become hyperexcitable and fire uncontrollably. This imbalance is the key target of anticonvulsants or anti-epileptic drugs.
And this is finally where the drugs come in. How do anti-epileptic drugs actually fix this imbalance?
Anti-epileptic drugs work by reducing neuronal excitability. They do this through three main mechanisms, either blocking sodium channels, or blocking calcium channels, or increasing inhibitory activity, mainly through GABA. All of these actions help stabilize neurons and prevent abnormal firing.
Basically, anti-epileptic drugs calm down overreactive neurons.
Precisely. And these drugs are divided into two main groups, classical drugs and newer drugs. Classical drugs are the most important and most commonly used ones. They include phenytoin, carbamazepine, valproate, ethosuximide, benzodiazepines, and barbiturates. And then we have the newer drugs, like gabapentin, lamotrigine, and some other ones. But these are usually used when classical drugs do not work or cannot be used.
So the classical drugs are the foundation, and the newer ones are more like backups.
Yup.
Perfect. Now that we have covered our basics, let's dive into the first and one of the most important drugs you need to know, phenytoin. So Omar, let's start simple. What does phenytoin actually do?
Phenytoin works mainly by blocking voltage-gated sodium channels in a neuron. Remember, normally, sodium channels are essential for generating action potentials. When sodium enters the neuron depolarizes and fires. Phenytoin blocks the sodium influx, which stabilizes the neuronal membrane and prevents excessive firing.
So it's calming down hyperactive neurons by preventing sodium from entering.
Yes, and at higher concentrations, phenytoin also enhances inhibitory activity by potentiating GABA, which further suppresses neuronal excitability.
So phenytoin works in two ways. First, it reduces excitation by blocking sodium channels. Second, it increases inhibition by enhancing GABA activity at higher doses.
It's also important to remember that sodium channels exist not just in neurons, but also in cardiac muscle and in skeletal muscle.
So phenytoin can affect those tissues as well. Okay, now this is where phenytoin gets really interesting and honestly a little tricky. Its pharmacokinetics are very unique.
Phenytoin has erratic absorption, meaning its absorption from the intestines is unpredictable. Sometimes more is absorbed, sometimes less is absorbed, so its blood levels can vary significantly between patients. Because of this, therapeutic drug monitoring is required when a patient is taking phenytoin. We need to measure blood levels to make sure they stay in the safe and effective ranges.
So phenytoin requires monitoring because its absorption is unpredictable. But what's predictable and very famously known is its elimination kinetics.
Phenytoin shows a transition from first-order kinetics to zero-order kinetics.
Let's simplify this.
Okay, so at low doses, phenytoin follows first-order kinetics. This means the rate of elimination depends on the drug concentration. So the more of the drug that you have in your body, the more that gets eliminated. But as soon as you increase the dose, the enzymes responsible for metabolizing phenytoin become saturated. Once they're all saturated, elimination switches to zero-order kinetics. This means only a fixed amount of drug can be eliminated per unit time, regardless of how much of the drug is being present in the body.
So basically, at low doses, the body can keep up and eliminate the drug normally. But at higher doses, the system becomes overwhelmed and the drug starts accumulating rapidly.
Absolutely correct. That's why phenytoin can be very dangerous if dosing isn't carefully monitored, because even a small increase in dose can lead to a very large increase in blood concentration.
And this dramatically increases the risk of toxicity. When do we use phenytoin? In which types of seizures?
Phenytoin is effective in most types of epilepsy, especially generalized tonic-clonic seizures and partial seizures. But there's one very important exception. Phenytoin does not, and I repeat, does not work for absence seizures.
That's because absence seizures involve T-type calcium channels and not sodium channels. So blocking sodium channels doesn't fix the problem.
Yup, exactly. Since it's very good at its job, phenytoin is also used for preventing seizures during or after neurosurgeries, And for the very severe form of epilepsy, the one we just mentioned before, status epilepticus.
There are some other random and interesting uses for phenytoin as well, don't you say, Omar?
Oh, there absolutely is. We can use it for trigeminal neuralgia. And because it can also block sodium channels in the heart, it can also be used to treat cardiac arrhythmias.
Now, I know that phenytoin has some very classic side effects. What are they?
I mean, all drugs do, don't they? Some common adverse effects of phenytoin include gastrointestinal irritation, blood disorders, ataxia, diplopia, osteomalacia. But one of the most common side effects that you should definitely remember and keep in mind is gingival hyperplasia, or enlargement of the gums.
And they love to ask about this in the exams.
They really do. Another side effect they love to ask about is hirsutism, excessive hair growth.
Alright, so phenytoin causes hirsutism and gingival hyperplasia, among other adverse effects, but these two are pretty classic presentations. I don't think phenytoin is very safe in pregnancy, is it, Omar? Because if I remember correctly, it is teratogenic.
Oh, you're absolutely right. It causes fetal Hayden-Towen syndrome. The baby would have features like mental impairment, cleft lip, low set ears, and nail hypoplasia. That's why phenytoin is contraindicated in pregnancy.
And I just remembered, phenytoin has some major drug interactions.
It does. Phenytoin is a strong enzyme inducer. This means it increases the metabolism of other drugs, making them less effective. Some drugs in particular are affected are oral contraceptives, barbiturates, carbamazepine, digoxin, doxycycline, and ethanol.
So when phenytoin induces the phytochrome enzymes, they break down drugs faster, so the drugs are not reaching their intended effect.
This is specifically important with oral contraceptives because it can lead to contraceptive failure.
We said that phenytoin is contraindicated in pregnancy due to its teratogenic effect. But I'm guessing that's not the only contraindication, is it?
It definitely isn't. Phenytoin also has an effect on heart muscles, don't you remember?
La. Remind me.
Sure thing. It can cause bradyarrhythmias, meaning low heart rhythms, so it should be avoided in patients with cardiac conduction problems.
Now that we understand phenytoin, the next drug becomes a bit easier to understand because it works in a very similar way. Let's move on to carbamazepine. Okay, Omar, I'm not gonna lie, when I first saw carbamazepine, I immediately thought, great, another complicated anti-epileptic drug to memorize. Now that we understand phenytoin, I feel like maybe this one won't be as bad, would it?
That's the spirit. Carbamazepine isn't some completely new random drug. It actually works very similarly to phenytoin. So instead of starting from zero, you can build on what you already understand. Both drugs stabilize neurons and prevent excessive firing by affecting sodium channel dependent firing. So the big picture here is the same. Calm down hyperexcitable neurons by targeting sodium channels.
There has to be a difference though.
Oh, there sure is. But the good news is carbamazepine generally has fewer side effects compared to phenytoin.
Oh, so carbamazepine works in the same way, but it's a bit safer and more tolerable than phenytoin.
And that's one more reason why carbamazepine is one of the most commonly used anti-epileptic drugs. It's safer.
And what can we use carbamazepine for?
It's effective in most types of epilepsy, but just like phenytoin, it does not work. And I repeat again and again, it does not work for absence seizures.
So in general, drugs that mainly affect sodium channel related firing, like phenytoin and carbamazepine, aren't effective in treating absence seizures, which rely heavily on T-type calcium channel activity.
Yes, but carbamazepine is especially effective for the complex partial seizures. These are seizures that start in one area of the brain, usually the temporal lobe, and they do involve impaired consciousness.
So if you see complex partial seizures, carbamazepine is one of the classic treatment options, but you wouldn't use it for absence seizures.
Of course.
Does it have any special indications like phenytoin did?
It sure does. Carbamazepine has some important non-seizure uses. It's used to treat trigeminal neuralgia, which is severe nerve pain affecting the face.
Just like phenytoin.
It is. Both phenytoin and carbamazepine can be used for trigeminal neuralgia. Other than that, carbamazepine is also used as a mood stabilizer in mania.
So this isn't just an anti-epileptic drug, it's also used in neurology and psychiatry. How does carbamazepine behave? Is it also erratic?
It is erratic. Carbamazepine has a slow and erratic absorption. That means it's not absorbed in a perfectly predictable way, just like phenytoin. Its plasma half-life ranges between 10 and 30 hours, so it stays in the body for a significant amount of time. And again, just like phenytoin, carbamazepine is a strong enzyme inducer.
So it increases the activity of liver enzymes that break down drugs, which increases the metabolism of other medications, making them less effective.
That's exactly what it does. That's why carbamazepine has many drug interactions, just like phenytoin did.
And what about side effects?
Carbamazepine can cause sedation, ataxia, and mental disturbances, such as confusion or changes in mental function.
So sedation and coordination problems basically slows the nervous system down.
Because of these effects, it can impair a person's ability to perform tasks that require alertness and coordination.
Just like driving.
Exactly like driving. So patients taking carbamazepine need to be cautious, especially when newly starting the medication.
Again, pregnancy is always an important consideration with anti-epileptic drugs.
Of course it is. Carbamazepine is also teratogenic, meaning it can cause birth defects. This is partly related to its effects on important nutrients involved in fetal development. Because of this, its use in pregnancy requires careful consideration, and protective supplementation may be needed to reduce risk.
Now we move on to a drug that's different from both phenytoin and carbamazepine, and honestly, one of the most powerful and versatile anti-epileptic drugs. It's a name that you always hear a lot, valproic acid.
I love me a good change. Think of it this way. If phenytoin and carbamazepine are like specialists that work well in certain seizure types, valproate is more like a generalist. It works through multiple mechanisms, which makes it effective in a wider range of seizure types. Once you understand its mechanisms, you'll see why it's so versatile.
Let's see it then. What does valproate actually do in the brain?
Okay, so valproate works mainly by increasing the activity of GABA, which is the brain's most important inhibitory neurotransmitter. Normally, GABA helps calm neurons down and prevents excessive firing, but GABA is constantly being broken down by an enzyme called GABA transaminase. Valproate inhibits this enzyme, GABA transaminase. So when this enzyme is inhibited, GABA is no longer broken down as quickly. So you get an increase in GABA concentration in the brain.
And since GABA is inhibitory, this increased GABA activity suppresses neuronal excitability and helps prevent seizures. So basically, valproate increases the brain's natural calming signal.
And that's not all. Valproate also works by blocking voltage-dependent sodium channels, similar to phenytoin and carbamazepine. This further stabilizes neurons and prevents excessive firing. And if that wasn't enough, there is one more important mechanism. Valproate also reduces T-type calcium currents, especially in the thalamus. And this is extremely important because T-type calcium channels play a major role in absence seizures.
Oh wait, we said that phenytoin and carbamazepine don't work for absence seizures because they don't block T-type calcium channels. But now we're saying that valproate does block T-type calcium channels.
Precisely. And that's why valproate can treat absence seizures while the other drugs we mentioned cannot.
So just to recap, valproate works through three main mechanisms. First, it increases GABA, which increases inhibition. 2, it blocks sodium channels, which reduces excitation. And it blocks T-type calcium channels, which prevent abnormal thalamic firing involved in absence seizures.
And this combination makes it an effective drug across multiple seizure types.
We said we can use it for absence seizures, unlike the other two. What else?
It's also effective in partial seizures and in generalized tonic-clonic seizures. So unlike phenytoin and carbamazepine, valproate also works in major seizure types, but also in absence seizures.
So it covers a broader range.
It absolutely does. And just like the last two drugs we mentioned, it also has another important use. It acts as a mood stabilizer in bipolar disorder. Another one we just talked about had the same indication. Do you remember that one?
Oh yeah, that was carbamazepine.
Way to go, Yazan.
Okay, now let's talk about side effects, because I know valproate has some important ones.
Oh, it absolutely does. And some of them are very important clinically. Common adverse effects include gastrointestinal symptoms like nausea and digestive discomfort. It can also cause tremors, sedation, and ataxia, which means impaired coordination. Some patients may develop skin rashes, and one very characteristic side effect is alopecia, which means hair loss.
Now, patients would definitely notice hair loss.
Oh, I'm definitely noticing my hair loss. There is one more pretty severe adverse effect, and that is liver toxicity. Valproate can cause fulminant hepatic failure, which is rare, but potentially fatal. So liver function must be monitored in patients taking valproate.
And I'm guessing this is also teratogenic.
I'm guessing you're correct too. Valproate is highly teratogenic. It can cause neural tube defects, especially spina bifida. This happens because the neural tube development is very sensitive to disruptions during early fetal development. So whenever you see valproate and pregnancy together, you should immediately think of spina bifida risk.
Alright, so valproate equals spina bifida. Okay, Omar, so we said valproate is the kind that covers everything, but now we're moving to a different drug, and this one is more targeted. This next drug is considered the most specific and most effective treatment for absence seizures, ethosuximide.
Ethosuximide is the definition of a laser-focused anti-epileptic drug. It's mainly famous for one thing. It's the most effective drug for absence seizures.
It ties back to the fact that absence seizures have a different pathophysiology.
That's exactly where it ties back. Remember, absence seizures have a strong link to the thalamus, and specifically to a type of calcium channels called T-type calcium channels. Calcium entering neurons can create a partial depolarization of the neuronal membrane even when the cell is resting, and that makes the neuron more ready to fire an action potential when a stimulus comes. So calcium currents basically help set up the neuron to fire.
So calcium influx kind of primes the neuron, making it easier to fire.
Now here's the key. In absence seizures, the main culprit is the T-type calcium channels in the thalamus. So the most logical thing to do is block those channels.
So ethosuximide blocks T-type calcium channels?
That's exactly what it does. Ethosuximide works by blocking T-type calcium channels, especially in the thalamus. And because it targets the mechanism that produces absence seizures, it becomes the main drug used to treat absence seizures. So while other drugs might work for many seizure types, ethosuximide is basically the absence seizure specialist. It is described as the most effective for absence seizures, and it's considered the main drug used to treat them because of the T-type calcium channel blockade.
So basically, absence seizures equals thalamus plus T-type calcium channels, which in the end equal ethosuximide. Okay, now side effects. What should we know?
Ethosuximide is actually known for having relatively fewer unwanted effects, which is nice compared to one of the heavier anti-epileptics. It still has some key side effects you need to recognize. The main ones include gastrointestinal issues, especially nausea and anorexia, which means the loss of appetite. It can also cause mental disturbances, which is a general way of saying it can affect mood or mental state in some patients. And it can cause hypersensitivity reactions, meaning allergic type reactions.
Overall, it's relatively mild, but we still remember nausea, anorexia, mental changes, and hypersensitivity reactions.
Precisely.
Okay, enough with the sodium and calcium channels. Let's talk about GABA with benzodiazepines.
I love a switch in topics, Yazan. We've been talking about sodium and calcium channels for a while now. Let's switch to GABA. Benzodiazepines are known as sedative, hypnotic, and anxiolytic drugs. So even outside seizures, they calm the nervous system down. But for seizures, the key idea is that they don't turn off neurons directly. Instead, they help GABA do its job better.
So they're not replacing GABA, they're just helping it.
Precisely. No one likes to be replaced, not even GABA. Benzodiazepines bind to something called the GABA receptor complex. And it's called a complex for a reason, because it's not just one binding site. It's a big receptor structure with multiple binding sites for different ligands. Now, in this complex, benzodiazepines do not, and I repeat again and again, do not bind to the same site where GABA binds. They bind to a different site, an allosteric site.
So think of it as someone adjusting the settings on the receptor, and not the person actually pressing the GABA button.
Perfect analogy, Yazan. And what happens when benzodiazepines bind is that they increase the affinity between GABA and its receptor. Meaning, when benzodiazepines are there, GABA can bind more effectively and do a stronger inhibitory job than it would on its own. Now, once GABA binds, the main effect is to open chloride channels. Chloride goes into the neuron, and the neuron becomes more negative, more hyperpolarized, so it's harder to fire.
In a nutshell, GABA makes the neuron more relaxed and less likely to fire, which stops the seizure activity.
Now, the signature feature of benzodiazepines, which you really don't want to miss, is that benzodiazepines increase the frequency. I repeat, the frequency of opening the chloride channels. So they make the channel open more often, in contrast to another group of drugs that we will discuss in a second.
The barbiturates, right? I know they also work on GABA.
They definitely do, and you're right. We'll get to them in a second.
What exactly is the difference between them?
Benzodiazepines increase the frequency of opening, how often the channels open. Barbiturates increase the duration of time through which the channels are open.
Oh, okay.
And there is one more comparison point that helps you understand why barbiturates can be more dangerous. At high concentrations, barbiturates can actually bind in a way that directly activates the GABA receptor and not just boost it, meaning they can push inhibition much more than we want them to. Benzodiazepines do not come in the same direct way. They mainly work by enhancing GABA's effect through that allosteric site, and that's it.
So barbiturates are just tryhards when they're at higher concentrations. Let's focus back on benzodiazepines. What are the indications for using them?
The most important clinical use here is status epilepticus. As we mentioned, the emergency seizure. And the specific drug is diazepam. It's a type of benzodiazepine that is preferred in status epilepticus. So if someone actively seizing and you need rapid control, benzodiazepines, especially diazepam, are the frontline seizure stoppers in that emergency context.
So in the emergency setting, benzodiazepines come in fast, enhance GABA, increase chloride influx, calm the brain down, and stop the seizure.
Good job, Mr. Qawas.
Let's shift back to the other side of GABA drugs. Right to the barbiturates, specifically phenobarbital.
So, like we said, barbiturates bind to the GABA receptor complex, not the main GABA binding site itself, just like benzodiazepines. They bind to their own site on that receptor complex, which allows them to enhance GABA's inhibitory effect, very similar to benzodiazepines. But here comes the difference. When GABA binds to its receptor, chloride channels open, chloride ions enter the neuron, and the neuron becomes more negatively charged or hyperpolarized. This makes it much harder for the neuron to fire. Barbiturates enhance this process, like benzodiazepines, just like I said, but with a twist.
Benzodiazepines increase the frequency of chloride channel opening, while barbiturates increase the duration of chloride channel opening. I actually just thought of a little mnemonic. We said that benzodiazepines increase frequency of chloride channel opening, and barbiturates increase duration of opening. So that you don't mix the two up, you can remember it by saying barbiturate for duration.
Ya aini عليك. I'll definitely be using that mnemonic.
You also said that the barbiturates are trihards when they're at higher concentrations.
They definitely are. And that's one more important difference that makes barbiturates more powerful and more potentially dangerous. As we said, when phenobarbital is at higher doses, it can actually activate the GABA receptor directly, even without GABA being present. So instead of just helping GABA, it can directly force the inhibitory effect. This means it can produce very strong suppression of neuronal activity.
And if I'm not mistaken, barbiturates are also inducers of liver enzymes, just like some of the drugs we discussed earlier on this episode.
That's absolutely correct. Phenobarbital is a strong inducer of macrosomal liver enzymes. This means it increases the activity of liver enzymes that break down drugs. So phenobarbital can increase the metabolism of other medications, getting rid of them quickly, which can make those drugs be less effective. Do you remember which two anti-epileptics of what we've discussed so far do the same thing, Yazan?
Carbamazepine and phenytoin.
A+, Yazan.
Tell me, Omar, when do you use barbiturates or phenobarbital?
Phenobarbital is useful in treating generalized tonic-clonic seizures. It's also used in status epilepticus, especially when other drugs aren't enough. So just like benzodiazepines, barbiturates can play a role in seizure emergencies.
Now let's talk side effects. What happens when someone takes phenobarbital?
The most common side effect is sedation. Now, something quite dangerous is that over time, patients can develop tolerance to the sedation, meaning the sedative effect becomes less noticeable. Other than sedation, at higher doses, phenobarbital can cause nystagmus, which is involuntary eye movement. And it can cause also ataxia, meaning impaired coordination and balance, just like a lot of the drugs we just mentioned.
So again, slowing down the nervous system, but sometimes it can be too much.
هو ده. Now, there's an important behavioral effect that you need to know, especially in children. Instead of sedation, children can develop the opposite reaction: paradoxical irritability, hyperactivity, and behavioral changes. So instead of calming down, they can become more agitated if they're taking barbiturates.
That's actually really interesting. So the same drug can calm adults, but at the same time overstimulate children.
Si, senor.
Okay, Omar. Now that we've covered the classic anti-epileptic drugs that everyone fears, there's still this whole second group that always makes people panic: the newer anti-epileptic drugs.
I know exactly what you mean. After all, they're new and people fear the new. But there is good news though. These newer anti-epileptic drugs are usually not the first thing you want to jump to. They're more like the backup options, used when the classic drugs do not work well enough, or if someone can't tolerate them. So we'll keep it simple.
First up on the list is gabapentin. Right off the bat, from the name, it sounds like it's literally saying it's somehow linked to GABA.
And it is. You're not wrong, because gabapentin is actually an analog of GABA, meaning its structure resembles GABA. But here's the key twist. Gabapentin does not act on GABA receptors. So it looks like GABA, but it doesn't sit on the GABA receptors. And the exact mechanism here is actually unknown.
Interesting. So if I'm being tested, I should not confidently claim it stimulates GABA receptors.
Do not fall into that trap. What you should remember is what it's used for. It's indicated for partial seizures, and it's also used for post-therapeutic, neuralgia, and chronic pain.
Next on line is lamotrigine.
Lamotrigine is very versatile. It blocks sodium channels and it also blocks voltage-dependent calcium channels. So essentially, it reduces abnormal firing by calming the neuron down through those ion channels effects we just mentioned. Remember, sodium and calcium. And because of that, it's effective in partial seizures generalized seizures, and even absent seizures. And another plus that's good to know is that it's used in bipolar disorder.
Crystal clear. Lamotrigine covers multiple seizure types as well as bipolar disorder. Now, what about tiagabine?
Tiagabine works by interfering with GABA reuptake. So instead of directly opening channels, it basically increases GABA's effect by keeping more GABA available in the synapse. More available GABA means more inhibition, means less neuronal firing. A little memory hack I like to do is saying tiagabine keeps GABA in the synapse. You see me?
Topiramate. Enlighten us, Omar. What does it do exactly?
Topiramate works in two ways. The first mechanism is that it blocks voltage-dependent sodium channels, especially during high-firing frequencies.
Which is exactly what happens in seizures.
And it also increases the frequency which GABA opens chloride channels. So more chloride channels opening. But there is a very important twist. It does this at a different sites than benzodiazepines. So the effect sounds similar,
More chloride channel opening frequency.
but the binding site is not the same as the benzodiazepines.
So the outcome is the same. Topiramate boosts GABA chloride activity just like benzodiazepines, but not by the same binding site.
Precisely.
Okay, we're almost at the finish line now, Omar. Moving on to felbamate.
I'm really sad we're nearing the finishing line. I mean, after all, who doesn't enjoy talking about anti-epileptic drugs? Anyways, mechanism-wise, felbamate does a few things. Firstly, it blocks voltage-dependent sodium channels at high firing frequencies. Second, it also blocks glutamate NMDA receptors, so it reduces excitation from the glutamate side too. And finally, it potentiates GABA-evoked responses, meaning it strengthens inhibitory effects mediated through GABA.
So overall, it decreases the excitation through decreasing sodium and NMDA firing, and it increases the inhibition through increasing the GABA response.
Precisely. Felbamate hits seizures from multiple angles. Less sodium firing, less NMDA excitation, and stronger GABA inhibitory response.
Now, what about zonisamide, Omar?
Zonisamide blocks voltage-dependent sodium channels and T-type calcium channels. It also enhances GABA transmission.
Nice. So it decreases excitation and increases inhibition, and it has both the sodium channel side and the T-type calcium channel side. And finally, Omar, last but not least, pregabalin. People confuse it with gabapentin all the time.
I get what you're saying. For a second there, I was like, didn't we already do this drug? Alright, pregabalin has two key actions. First, it increases neuronal GABA. Second, it causes a decrease in neuronal calcium currents by binding with voltage-gated calcium channels. Basically, the neuron has less calcium-driven activity and more inhibition.
Pregabalin causes more GABA effect and less calcium current. Okay, never thought we'd see this moment, Omar, but we're finally here. We're done with all the anti-epileptic drugs. Now, let's get into a true emergency. Status epilepticus. What exactly does that mean?
Truly a topic I've been waiting to talk about since the beginning of our episode. Status epilepticus basically means the seizures are happening so close together that the brain doesn't even get a chance to recover in between. So instead of saying seizure, recovery, then back to normal, what we see is seizure after seizure after seizure. And clinically, it can look like continuous convulsions with no real stop. That no recovery between attacks is the key idea.
In simple words, the brain is basically stuck in seizure mode.
Exactly, it's a medical emergency. The goal is to stop the seizure activity really fast.
All right, so now that we know what status epilepticus is, which anti-epileptic drugs do we use? Or how do we manage it?
The emergency options include, first, IV lorazepam or diazepam. And remember, those are benzodiazepines, fast-acting drugs that enhance inhibition through GABA. Then, we can use IV phenytoin. And if you still need more control, we can do phenobarbital as well. In severe cases where you need full control with anesthesia, you can also use midazolam or propofol.
So the lineup is as follows. First, we have IV benzodiazepines, such as lorazepam or diazepam. Then we have IV phenytoin. And last but not least, we have phenobarbital. And if it's really not stopping, anesthesia with midazolam or propofol will do the job. Okay, now this is the important part everyone wants to know. Let's discuss the first line drug for each seizure type. Keep in mind, there's also second choice drugs and alternatives, but we don't want to overwhelm you with a list of drugs. So we'll focus on the first line mostly.
I get what you mean. After all, first line drugs are what they ask the most about in exams. So let's do it. So for generalized tonic-clonic seizures, our first choice is phenytoin or carbamazepine.
For absence seizures, the first choice is, can you guess it?
Of course I can. Ethosuximide.
If you got this one wrong, I would have thrown this mic at you.
You wouldn't dare. For myoclonic jerks, the first choice is valproic acid.
And for status epilepticus, the first line is IV diazepam and IV phenytoin.
And finally, for partial seizures, first choice is phenytoin or carbamazepine.
Alright, now that we've covered the newer anti-epileptic drugs, status epilepticus, and the drugs of choice, we're ready to tie it all together with a final recap.
We set the scene by defining and introducing what epilepsies and seizures are and what are their differences, and we'll go over it all again. We defined epilepsies as recurrent, unprovoked seizures from abnormal excessive electrical firing in the brain. One way you can diagnose epilepsies is an EEG, an electroencephalogram, which is basically a diagnostic tool placed on the scalp that helps you identify or diagnose epilepsies and seizures.
After that, we cleared the common confusion. A seizure can be a one-time event from many causes, while epilepsy is a chronic condition with 2 or more unprovoked seizures. So these drugs are really anti-seizure meds, not just anti-epilepsy.
Then, we broke seizures types into a clean map, partial versus generalized. Partial starts in one specific area in the brain, simple partial keeps consciousness, complex partial impairs consciousness, and often has an aura with the post-event confusion.
On the other hand, generalized seizures start in both hemispheres from the beginning. This is the classic tonic-clonic with tonic stiffening, clonic jerking, and recovery phase. There is also the absence seizures in kids with brief staring spells under 30 seconds, no convulsions, and easy to miss.
We also listed the extra types: atonic drop attacks, myoclonic jerks, infantile spasms, and we emphasized status epilepticus as the dangerous one, the emergency case, where there are repeated seizures with no recovery in between. This has the risk of either brain damage or, in some cases, death.
Then we connected it back to the basics. Neuronal excitation is mainly glutamate letting sodium and calcium in, while inhibition is mainly GABA and glycine, bringing chloride in and pushing potassium out. Epilepsy is basically excitation winning over.
Which leads us to the master rule of this entire episode. Anti-epileptic drugs reduce excitability by doing one of 3 things: blocking sodium channels, or blocking calcium channels, or boosting GABA inhibition. We generally use classic drugs first, then, if needed, we might need the newer drugs.
We kicked off with the classics, such as phenytoin, which blocks voltage-gated sodium channels to stop rapid firing, and at higher levels, it also enhances GABA, so it calms neurons down from 2 angles.
Phenytoin has this erratic absorption that needs monitoring, and it switches from first order to zero order kinetics when enzymes saturate, so small increases in the dose can spike levels and cause toxicity.
Then we locked in its clinical use, which is great for tonic-clonic and partial seizures, used in status epilepticus and seizure prevention around neurosurgery, but absolutely not for absence seizures.
Plus the classical side effects they love to ask about in exams: gingival hyperplasia and hirsutism, along with neuro effects like ataxia and diplopia. Then we flagged the pregnancy risk, which is fatal Hayden-Towen syndrome.
And remember the interaction, phenytoin induces liver enzymes, so it can reduce the effectiveness of other drugs, especially oral contraceptives. Phenytoin can also worsen conduction problems due to cardiac effects.
Moving on to carbamazepine, similar sodium channel mechanism, usually more tolerable than phenytoin, strongest association with complex partial seizures, and it doesn't always work for absence seizures.
Carbamazepine is also used for trigeminal neuralgia and mood stabilization in mania. It also has slow, erratic absorption and enzyme induction, causing drug interactions.
Then we shifted to the big generalist, valproate. It boosts GABA by inhibiting GABA transaminase, blocks sodium channels, and blocks T-type calcium currents. Because of these 3 mechanisms, it covers partial, tonic-clonic, and absence seizures.
Now, valproate can cause alopecia as well, but don't forget, a more serious adverse effect is hepatotoxicity, to monitor liver function. In pregnancy, it equals neural tube defects, especially spina bifida.
Then came the absence specialist, ethosuximide. We tied absence seizures to the thalamus and T-type calcium channels, so ethosuximide works by blocking T-type calcium channels right at the source, the thalamus.
Ethosuximide causes GI side effects like nausea, anorexia, and then some mental changes and hypersensitivity reactions, but overall lighter compared to many others.
Then we pivoted to the GABA helpers, starting off with benzodiazepines, which binds allosterically to the GABA A receptor complex, increases GABA's effect, and increases the frequency of chloride channel opening. We mainly use benzodiazepines for rapid control in status epilepticus, especially diazepam.
Then we contrasted barbiturates like phenobarbital. This increases the duration of chloride channel opening, and at high doses, it can directly activate the receptor, making it more powerful and more dangerous.
We also discussed enzyme induction in barbiturates like phenytoin and carbamazepine. We use barbiturates in tonic-clonic seizures and status epilepticus, and its side effects include sedation, nystagmus, ataxia, and paradoxical hyperactivity in kids.
After the classics, we talk about the newer anti-epileptic drugs, which are mostly backup options.
Starting off with gabapentin. Looks like GABA, but doesn't really act like GABA. And as we said, its mechanism of action isn't really clear. But remember the uses: partial seizures and neuropathic pain like post-therapeutic neuralgia.
Lamotrigine blocks sodium and voltage-dependent calcium channels, so it covers partial, generalized, and absent seizures, and it's also used in bipolar disorder.
Tiagabine blocks GABA reuptake, so more GABA stays in the synapse, more inhibition, less firing. And to remember, think tiagabine keeps GABA in.
Topiramate blocks sodium channels at high frequency firing and increases GABA-related chloride channel opening frequency, but at a different site than benzodiazepine.
Felbamate hits from multiple angles: sodium blockade, NMDA glutamate blockade to reduce excitation, and stronger GABA responses to increase inhibition.
Zonisamide blocks sodium channels, blocks T-type calcium channels, and enhances GABA, so it covers both the sodium story and the absence-style calcium story.
Moving on to pregabalin, which has more GABA effect plus decreases calcium current by binding voltage-gated calcium channels.
Then we close with the true emergency: status epilepticus, seizure after seizure with no recovery, brain stuck in seizure mode, so you stop it fast.
And the treatment ladder: intravenous benzodiazepine first, for example, lorazepam and diazepam. Then we move on to intravenous phenytoin, then phenobarbital, and if nothing else works, as we said, if needed, anesthesia like midazolam and propofol.
Finally, we discussed when to use each drug. For tonic-clonic, we use phenytoin and carbamazepine. For absence, we use ethosuximide. For myoclonic, we use valproate. And for partial, we use phenytoin or carbamazepine. So if we simplify everything into one sentence, anti-epileptic drugs either block excitation, increase inhibition, or just do both. And that's a wrap on anti-epileptic drugs, everyone. Now, hopefully, instead of struggling like us with memorizing these drugs blindly, you actually understand how they work and when to use them and how they fit into the big picture.
I personally wish I had a PodBites episode to help me get through my anti-epileptic drugs lecture. But at the end of the day, like, who doesn't want to do them, right? Anyways, thank you guys for tuning into PodBites.
And we'll see you in the next episode.